Absolutely.
It's a little bit past 12. John, how many people are in the waiting room?
There's 13 people now. Shall I just let them all in?
Yes. Could you let them in? And then, Carl, should we get started in a couple of minutes?
Sure. Yeah, I got a lot of slides. I'm going to burn through some of them, but yeah, probably.
Okay, let's go ahead and
sooner.
start then. Yeah.
And you'll be sharing the slides as well, Carl?
Yes.
Okay, thank you. All right, I'll put myself on mute.
Okay, Carl, if you're ready, is it okay if I go ahead and introduce you and do the preliminary stuff?
You bet.
Okay, great. Okay, good afternoon, ladies and gentlemen, and welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speaker, I want to make a few housekeeping remarks. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine. Please make sure you complete the evaluation form. At this time, please enter the name of everyone in the room into the chat box for attendance purposes. Evaluations are necessary for CME and can be found either on our website or by following the link that will be entered into the chat box. As you know, all sponsors of CME are required to execute a conflict of interest policy. Dr. Steinberg has disclosed that he has no relationships with commercial supporters. It's my great pleasure to introduce our speaker for today, Dr. Carl Steinberg. He has been a nursing home and hospice medical director in the San Diego area since 1995. He received his bachelor's from Harvard, his medical degree from Ohio State University, and then did family medicine residency at University of California, San Diego. He's board certified in family medicine and hospice and palliative medicine, and also certified as a nursing home and hospice medical director. He serves as faculty for several sites for California State University, Case Western Reserve University, and the University of California at San Diego. He's currently the president-elect of AMDA, the Society for Post-Acute and Long-Term Care Medicine, and has many other national roles as well. So please join me in welcoming Dr. Carl Steinberg.
Thanks so much. I appreciate you guys having me. I've got quite a bit of content, and so I'm going to burn through some of these slides. Some of them are a little bit rudimentary, and I'll also apologize in advance, which you're never supposed to do, of course, because some of them are a little California specific. I did spend some time on the Kokua Mau site. You guys have a great site. I'm really impressed with it. Kudos to you. And so there may be a thing or two that doesn't correlate exactly, and I'll talk about some of the differences between the California and Hawaii POLST forms in particular. Today we're going to talk about how COVID has changed things, I guess, and also just reiterate how important it is to do advanced care planning to help people make really informed decisions about their medical treatments, and talk about some other of the nuances, strategies, I guess, for having conversations with patients and their families. Now, I'm a nursing home doctor for the most part, so they'll have a little bit of a nursing home slant, but hopefully it's relevant to everyone. Yeah, no conflict. So how is COVID-19 impacting conversations about advanced care planning and POLST? And from what I understand, in Hawaii, you have not had a great onslaught of severe COVID disease, which is wonderful. And in San Diego County, we also have not come anywhere near, the sort of surge that they've seen in other parts of the country. We're not running out of ICU beds or ventilators or anything like that. But we've had deaths. We've had a significant impact of the illness. So. And it is different from what we've seen before. And everything's different. I'm a little shaggy, and you might hear dogs barking because the dogs are here. Usually when you give a webinar, the dogs aren't necessarily around. So I just wanted to show you the Coalition for Compassionate Care of California, which I had the honor of chairing for a couple of years and still on their board. They have a COVID page. I see Kokua Mau has a really good page, so I don't know that you really have to check out the Coalition's page, but if you've got a little extra time, there are some other items that are on that. So what is advanced care planning? And I apologize if this is too rudimentary, so we'll kind of burn through these. But it's a series of conversations, usually between healthcare professionals and planning principals, patients, their families, and so on, about what's important to the individual. What are their hopes, what are their fears, and what are the actual realities of their medical condition. What kind of functional status do they have? How are they limited? And then, talk about treatment preferences if they have any. The benefits, I think, are obvious to anybody that works in our field and works with the population we work with. It increases the likelihood that people are going to get treatment that they want to get and not get treatment they don't want to get. That may be the most important thing, the sort of basic reason behind it all. It also helps people at a time in their lives when they don't have control over a lot to exert a sense of control over the things that they can control, like whether they go to the hospital or not, or what sorts of medical torture is going to be visited on them, and so on. Kind of paradoxically, it can really strengthen relationships, not just between healthcare provider and patient, but also between the patient and their family members as they have these meaningful discussions. And I hope most people on the call here have already done this. And I think when you do this with your family, you understand that it does strengthen the relationships, and it gives you a kind of a deeper appreciation of people's desires and wishes and so on. It also is really good at relieving guilt. Now, nothing will completely relieve guilt for making a decision, let's say, not to put a feeding tube in somebody or to request a DNR order, but it really helps. It goes a long way. It makes sharing of medical information easier, because you have somebody named in your advance directive. Obviously, the healthcare team can discuss freely with them, and it provides opportunities to kind of address life closure. For healthcare providers, it helps us provide truly person-centered care, individualized care, and again, avoid unwanted or unnecessary care. And there's always that sort of hint of, or that whiff of death panel talk. And just so everybody's clear, the reason for advanced care planning is not in any way to save costs or reduce costs or anything like that. I mean, that can be a side benefit of it, but that's not the reason we do it. We do it so that we, give people care that's concordant with their wishes. It helps improve our relationship with our patients and families, and it helps reduce moral distress, because if we're doing something that may hasten somebody's death, at least we know that's what we're doing, what they would want. So does COVID change this? This is our sort of protocol that we use. Everybody 18 and up should complete an advance directive. And this is a good time right now to ask young people to do this, because young people are dying of COVID, right? But normally you might say, well, hey, anybody could go out and get hit by a truck or anything like that. But now people are actually dying of medical disease at a young age. So if nothing else, to at least identify a person to make decisions on their behalf. And you update it periodically, right? You do every decade if you have a new disease, a new disability, the 5 Ds, which many of us may not always do that. Divorce is another one, right? And then if you're diagnosed with a serious illness or progressive illness at any age, then you consider a POLST form. And we'll talk a little bit more about what's really appropriate for POLST, because I think POLST gets abused and just used as a code status document when really that's not what it should be. And then hopefully your treatment wishes are honored and you get the treatment you want to get and you don't get the treatment you don't want to get. So what do we need to hear from our patients? probably number one most important thing, who would you want to make decisions for you if you weren't able to speak for yourself? And then also very important, are there some particular things that you definitely would or wouldn't want? And then the bigger picture is what makes your life worth living? You know, what are some things that you wouldn't want to live without? Are there things that you want to do before you die? You know, you've got a graduation or a wedding coming up. And what kinds of things are not acceptable, right? What would be a deal killer for you? You know, for some people, it could be something as simple as being incontinent. For other people, it would have to be, you know, excruciating, unrelenting pain. And then, you know, there are specific things that are based on, you know, like a Jehovah's Witness that doesn't want to get transfused and that type of thing. So what do the patients need to hear from us? Well, and I'll temper this by saying not everybody wants to hear it. So you always want to ask first, right? You don't just, you know, blow out a whole bunch of diagnoses and prognoses on people that don't necessarily want to hear it. But assuming, as most people do, that they want to know what's wrong with them and what they realistically have to look forward to, their diagnoses, you know, how those diagnoses are likely to impact their sense of well-being and their functional status and physical symptoms. What's the natural progression of the illness? And I think right now with COVID-19, in our geriatric population, and especially with people with multimorbidities, that's an important conversation to have. And then, you know, what are the various treatment options and probable outcomes? You know, risks, benefits, that's that whole informed consent conversation. What would happen if we didn't do anything to try to modify your disease path versus what if we did the most aggressive, sort of like these discussions you might have about chemo or radiation or things like that. And then I think it's important to discuss comfort-focused interventions because we give everybody comfort care, but you know, some people may not be aware of the availability of things like palliative sedation and that. So keep that in mind. So an advance directive, this is a tool so that somebody else can speak for you. And I looked at the Hawaii, your kind of standard advance directive, and it's similar to the one we have in California and a lot of places where basically it says, I don't want my life prolonged, you know, A, if I'm in a persistent vegetative state, B, if I have a terminal condition and the application of life-sustaining treatment will only serve to delay the moment of my death, or C, under any other circumstances where the burdens of treatment outweigh the expected benefits. And obviously that means something very different to everybody, right? And so, you know, an advance directive is somewhat helpful. It says, I don't want my life prolonged excessively, but it doesn't get specific, right? And you can put specific instructions in your advance directive, like I don't want to be on a ventilator or I don't want a feeding tube. But ultimately, it gives the person the right to do that. And probably some of you have had situations where it says right there in black and white, no feeding tubes, but the family member, when push comes to shove, says, well, I just cannot let my husband die of starvation. And so I think under these circumstances, he'd want a feeding tube, and it creates a horrible conflict. These are just some possible documents. But I think the most important thing when we all do our own advanced healthcare directives and when we instruct our patients and our loved ones is to make sure that you pick the right person, right? So it should be somebody who's available and who's able to make decisions that are based on what you would want, not what their beliefs or what their values are, or that they don't want to lose you. And so that's not always a spouse, as you're clear. I mean, as we've all seen in some clinical instances, and that somebody will actually be able to advocate for you, right? And whether that's to request more aggressive treatment, less aggressive treatment, somebody that's going to really stand in your shoes. I'm not going to spend a lot of time on this. There's in California, and I believe also in Hawaii, there's some preclusions on who can serve as a surrogate on an advanced directive. Also, I believe you need 2 witnesses. You don't have to have a notary, but you can have a notary. But a lot of times people think these are super complicated documents. They're easy, and you don't have to hire anybody, just get a couple of neighbors to sign it. Although during this pandemic, it's a little bit harder to probably get somebody to witness. And I'm not sure what they've done in Hawaii, if anything, to make that a little bit easier. But in California, we're requesting an executive order to relax some of the witnessing requirements. But there are creative workarounds for most people. It's just that some of the geriatric population doesn't have access to technology, and that makes it a little bit trickier. Okay, so let's get into POLST. I want to mention that, so I'm vice president of National POLST, and they're keeping the word POLST, which used to be this acronym. And like in California, it's still called, by law, it's called Physician Orders for Life-Sustaining Treatment, even though a PA or a nurse practitioner can sign it. But basically, National POLST is trying to get away from that, especially since it has, 13 different names across the country. And they're just calling it basically portable orders, portable patient orders, right? And part of the reason is because it's not just a physician who can sign it, and part of the other reason is because the word life-sustaining treatment is a little bit value-laden, and as we all know, probably doing chest compressions on a 78-pound 100-year-old is not life-sustaining, right? So it's a portable order about specific types of treatment. It's legally binding across healthcare sites in each state where there's a POLST paradigm form. And there's a varying degree of reciprocity in other states. So, but if you want to be on the safe side and you're somebody who, splits their time between states, it's better to have one from each state at this point. And National POLST is working on sort of reciprocity, but right now, because there's not a standard POLST form, that's a little bit tricky. It has to be appropriately signed, and believe it or not, there's some states where it doesn't require the patient or family member to sign. It only requires a healthcare professional signature, but most places like California and Hawaii, it's got to have both. And I think if there's one important take-home point, it's that POLST is not for everybody. It's not like an advanced directive that everybody should do. It's really for people who are nearing the end of life. So people who have a serious illness, medically frail, a chronic progressive condition, and the surprise question, which they're taking to mean you wouldn't be surprised if this person died in the next year or two. So it's a little squishy, but it's been shown to have some, you might hear a dog bark here in a minute. It's been shown to have some statistical, there's some actual correlation with people's prognosis. So anyway, it's not for everybody, right? So I think it's important to explain one reason why is because a lot of nursing homes, and in California, there are facilities that do this. They basically mandate POLST as part of the admission paperwork, right? So every patient gets a POLST. And so a lot of people just, they're not in the last year or two of life, and they just want ordinary care. So yes, if they were to go down, they would want an initial attempt at CPR and counter shock and whatever all else. Those people, when they fill out a POLST form, then subsequently lose decisional capacity. It kind of creates a conflict later if a family member says, well, no, I don't think he would want to, this aggressive treatment. And they'll be like, but look, he signed this form saying he did. So that's just one of several reasons. Anyway, what are with this COVID crisis, is it different? Does this expand the population, right? Does anybody who's geriatric, because if you looked at the statistics out of New York, people did very badly. People who got actually sick from from COVID and wound up in a hospital on a ventilator, I think there was only about a 3% survival rate. So anyway, that's something to consider. And this, you guys know this, and I saw this on your website too, just the difference between advanced directives and POLST. So to me, one of the most important things about POLST is it's actually in order. So a first responder has to obey it, and that's a good thing. So this is the California POLST. I know it's kind of similar to you guys. Most important thing about Section A of the POLST form is when does Section A actually apply? And you guys have something similar. Okay. Basically, Section A applies only if the patient has no pulse and is not breathing. You know, I went to the Ohio State University College of Medicine, where I learned that if you have no pulse and you are not breathing, you are dead. And so a lot of times people would be like, oh, I don't want to make my mom a DNR. I know what that means. That basically means you're just going to let her die. That is not what DNR on a POLST form means, right? DNR means if you find me dead, don't try to bring me back, right? It's only for people who have no pulse and are not breathing. So that's super important. And when you're having these discussions with people, it's super important for them to understand that. Section B, I showed both because you guys still are using this language in the bottom one. This is our old one, limited interventions. And we changed that to selective treatment about 6 or 7 years ago. Instead of comfort measures only, we call it comfort-focused treatment and sort of using these goal statements, which I really like. Now, National POLST has come out with a template for a National POLST form, and if you go to polst.org, you can find that. There's already, I think, maybe about 3 states that have adopted the National POLST form. One thing that it lacks is the under selective or limited, this box, and I don't think you guys have it either. It says transfer to hospital only if comfort needs cannot be met in current location, or basically a DNH or do not hospitalize order. So that's something that on the National POLST form and on your own POLST form, I suspect you do it from time to time, as you just write in under the free text section, do not hospitalize, and that sort of thing. So we'll talk a little bit more about Section B. Full treatment is everything. So people can be DNR, meaning if my heart stops and I stop breathing, leave me alone, allow natural death. But if I'm having trouble breathing, I want to be put on a ventilator and so on. So that's full treatment. And sometimes people say, well, how can you be DNR but full treatment? But people with COPD, or let's say somebody with COVID pneumonia who's having respiratory distress, they may not want CPR if their heart stops, but they want to give it a go on the vent. But if you do pick yes to CPR, then you have to pick full treatment. So you can't. Sometimes I'll go into a nursing home where I'll be doing chart audits and I'll see somebody has checked yes to CPR and then they want comfort care, and it's like that. You're not allowed to do that, because if you pick CPR, you basically, that is the most invasive and aggressive treatment modality we have. So basically, you've bought the whole enchilada. And once you get to the hospital, things are different. But for paramedics, they're pretty black and white, and they need clear instructions on these things. The other nice thing that we have, which I also don't think you guys have on yours, is this trial period of full treatment. Because if somebody wants full treatment, so let's say they go on a vent, and then let's say 3 weeks later they're still on the vent. Now you're going to have to change their POLST orders if they didn't pick trial period of full treatment. So anyway, when you guys go to revise your form, I would consider adding those things. And I think because of COVID-19, we know that people are spending a lot longer on the ventilator. At Sharp Hospital here, we just had the first person come out of the hospital that had been on the vent with COVID. And this guy was on the ventilator for 5 weeks. And, they were wheeling him out of the hospital in a wheelchair. So that was pretty neat. But anyway, there's all these trach issues and that type of thing that normally you do that after 2 weeks. And you know, when people are on a ventilator for a couple of weeks, you know how deconditioned they get, and especially with the high pressures that we're needing with COVID, you know, we're doing some lung damage with ARDS, and so it may have an impact in your patient's decision making as to whether they want to go on a ventilator if they get COVID. They might say, look, if I just got a regular pneumonia or sepsis, you know, I'll go on a vent for a couple days, come off, you know, I would totally do that. But I don't really want to sign on to a big long ventilator, you know, experience. So here's some specifics about ventilators. You know, when you're talking to a patient, this is out of a story that Dr. Catherine Drager wrote. And, you know, if a person, do they want to be put on a ventilator if they're going to need to be on life support? And obviously they're going to have to be profoundly sedated. And then once they're on the ventilator, how far do they want to go? What if they start, what if the kidneys start to shut down, and, you know, they have to get nutrition? So then you're going to, you know, a lot of people would be like, oh, I don't want to be on a bunch of tubes and machines long term, but they might need a feeding tube. So let's move on to selective treatment on section B. And in my world, in the nursing home, this is what most people pick. Basically kind of like no heroics. Yes, I want to go to the hospital. Yes, I want IVs, antibiotics, that kind of thing. CPAP, BiPAP, maybe even a little pressors in the ICU, but I don't want the real invasive stuff. And then we do have this do not transfer option that we use for nursing home residents in California, saying that they want to stay put, and whatever we can do there, they'll take, but they don't want to be shipped to the hospital. And as you're well aware, a trip to the hospital for a stable long-term nursing home resident can sometimes be devastating. You know, they get delirious, and oftentimes they come back and they're never the same, even if they went in for something relatively minor, like a UTI or something. And then comfort treatment, everybody gets comfort care, whether you check that box or not. So that's, sometimes people want to pick that box because they're like, yeah, comfort is important to me, but they're not a true comfort care resident where that's the total focus, right? And so sometimes people will have a POLST already filled out at a nursing home when I'm going to do an admission. They'll check that box and I'll say, so you understand, if you got pneumonia, we'd probably just give you morphine and oxygen, right? I mean, we don't necessarily use antibiotics because it's not universally shown to be a comfort promoting measure. And they'll be like, whoa, wait a minute, that's not, you know, that's not what I want. I want, of course I want antibiotics. And people who choose this generally should be treated in place if they're in a place where they can receive appropriate treatment. Hip fractures are kind of a special thing. I'm a proponent of fixing a hip fracture, even if the person might die on the operating table, unless they're really in the last few days or week or two of life. Because if you don't, then every time you turn that person, it's, you know, they're in misery and that thing's flapping in the breeze. So, okay. And, you know, during this COVID pandemic, there may be more of a push not to send people to the hospital. So that's something that needs to be discussed on a case-by-case basis. And you can write anything in the free text. So what National POLST is suggesting is that some people may want to do a specific POLST form that only pertains to COVID-19. To me, that might be a little in the weeds, but for people for whom it's really different from their ordinary wishes, you can write that in. Or you could just say no intubation for COVID-related disease or those types of things. You can also put time limits on things, and again, you can't anticipate every single clinical scenario, so it's not always 100% that these things are going to be followed, but a lot of times they will. And it doesn't hurt to write it down, at least to let people know what you want. It's really good to check the advanced directive section and make sure it gets filled out. I'm not going to spend a lot of time on tube feeding. Just keep in mind that tube feeding is medically contraindicated in people with advanced dementia. Probably many of us still see tubes getting put in. I mean, AMDA, the Hospice Academy, American Geriatric Society, everybody has come out with their choosing wisely, saying don't put a feeding tube in advanced dementia patients. Of course, I haven't seen that yet in the from the interventional radiologists or the gastroenterologists, but in any event, we should be discouraging people from doing that. And Oregon, which is where POLST originated, decided to take this off their form. So they decided that because they felt it probably shouldn't even be on there as an option for many people, especially those with advanced dementia. I mean, to me, going by that, maybe CPR shouldn't be on there either, because for a lot of the people we take care of, the survival is so dismal. I mean, it's probably on the order of 1 or 2% that it borders on medical futility. Okay, so best practices. First of all, it's always voluntary, and it's not for everybody. And you know, a nursing home might say, well, we're not forcing them to fill it out, but essentially when you're sticking it under their nose with a whole basket of admission paperwork, the vibe is, yeah, you sign this. POLST should be revisited anytime there's an unexpected or significant change of condition, because people change their minds, right? And they change it in both directions. A patient who has decisional capacity can void or change a POLST at any time. And a surrogate decision maker can void or change a POLST, you know, when it's appropriate to the circumstances, but not capriciously. I'm sure you guys all know this, but just to reiterate, POLST is not just a checkbox form. I mean, POLST, it memorializes a meaningful and usually deep conversation. Sometimes the conversation can be really short, right? When somebody says, you know, I pray every night that God will take me, and if you do anything to try to prolong my life, then when I do die, I will come back and haunt your ass, so help me God. Okay, that, you know, after you've ruled out severe depression, you know, you don't have to have a long conversation. This person obviously wants comfort care. But anyway, I think the key elements in these conversations is, first of all, is the person willing to talk? And if they're not, are they willing for you to talk to somebody else who can make decisions on their behalf? Because otherwise, we default to the most aggressive treatment. And let's find out what they understand. So the best thing to do to start out is say, you know, tell us what you understand about your condition or conditions. And then what are your preferences as far as, can we discuss this with your family? Is it somebody that you want us to discuss it to, somebody that you don't? And it's always worth the time, even though it does take time, to make that extra phone call to a family member, or ideally have them there when you're having these conversations. And are there things that the person wants to hang around for, you know, like a wedding or a graduation? I think eliciting their fears and anxieties, what would constitute an unacceptable state of health, and what are the trade-offs that people will accept? Because a lot of people, like right now, will say, well, I wouldn't want to live if I couldn't, you know, walk under my own steam. But yet, you know, if they have a stroke or something, their attitudes change. And somebody who right now says, you know, I would want to fight. I want my life to be prolonged. You know, I'm young and healthy and whatever. Then when they get a terminal diagnosis, sometimes they're like, okay, I don't really want to fight this. You know, now that I have metastatic pancreatic cancer or something. And I think it's really important to elicit trust. And really for us as healthcare providers, we're really good at talking at people to, you know, to be able to dial it back, you know, bite your tongue and just listen, and be willing to talk about spiritual things, because those start to loom large for a lot of people when they're getting close to the end of life. So specifically with respect to coronavirus, you know, when we're getting ready to have these conversations, first thing to do is let's see if the person already has an advanced directive or POLST or other types of treatment preference documentation. And if so, you know, look that over first, and then make sure that that's still accurate when you go to have that conversation. And then, of course, take your own pulse, right? Make sure that you're in a place that you can be present, listen, and, you know, walk the path with the person. So is it okay if we talk about what's important to you and how this new coronavirus might affect you, so we can be sure that we give you the kind of care you want if you got the virus? And by the way, these are just some points that kind of came from a variety of other websites, including the Vital Talk, Ariadne, Serious Illness, CAPC, and Respecting Choices, and the Coalition for Compassionate Care of California. You know, this conversation can help you and your family, if you were to get it, we're hoping you don't get it, right? But if you were to get it, we just want to be sure that things are still as we've discussed before, or if not, we'll change them. And then make sure that they've designated somebody good to make decisions on their behalf. Then what do you know about the coronavirus? And would you like to know anything else? I think it's important for people to know that the prognosis once they get on a ventilator is pretty poor. And also the fact that one of the most cruel things about this virus is the lack of ability to have visitors, except when people are sort of actively dying, which is really hard. It's hard for the patient, it's hard for the family. Then how about, what are your other medical conditions? How are they affecting you? And do you have any idea how that might affect you if you were to get the coronavirus? Are there any particular things that you're especially concerned or afraid of? And then it can be hard to predict what would happen if you did get the virus, since you're already at risk for severe disease because of your whatever, COPD, chronic kidney disease. A lot of people get mild cases, and I hope you would be one of those, but I'm worried that you could get very sick very quickly, and just so that we're prepared, so that we can give you treatment that's in line with what you want. And believe me, when I've had these conversations with some people, they look at me like, what are you trying to say? No, of course I want the same treatment. I'm not ready to check out. But other people really do have, sort of a change of heart. Talk about goals. What are your most important goals? What are your fears? And again, what are some of the functional things that you would not want to live without? And have you talked to your family about this? It's hard to talk about it, but it's really important. And if you like, we can try to set up a time that we can talk with your family together. And then, to summarize, I think it's always important to acknowledge the person's emotion. And, for most people, they're afraid, there's fear. And to acknowledge that, especially somebody who's stuck in a nursing home where they're basically a sitting duck, right? And thank them for having the conversation. And then kind of reframe it. Like what I hear you say is that, these things are important for you. And, if you would be able to do this, or if you lost this ability, you wouldn't want to live, and kind of reiterate what's just been talked about. And then based on that, and based on your condition and what I know about the virus, I would recommend that we make these, orders, if you were to get the virus. And I hope things won't get worse, and I hope you don't get coronavirus, but I'm glad that we talked about it, just in case they do, because it is a possibility right now. And we're going to do everything we can to make sure you get the type of care you want to receive. And we're going to write orders to make sure that happens. Is there someone else you want me to talk about that, to explain what you and I just talked about? And then always important, I care about you, and I'm going to walk this path with you wherever it takes. Now, if I'm a nursing home doctor and I don't go to the hospital, that may be a little white lie. But I mean, I'm in it with this person, right? It's collaborative, and we do care about them, and that's super important. And this is something where it's nice to have that on the POLST form, as a pre-checked box, but you can always write it in. Risks of going to the hospital are greater than they usually are, because the virus is there. And even when we don't have a pandemic, it's much better to treat people in place. So, and obviously we can do IVs and a lot of things in nursing homes these days that we didn't used to be able to do. So, the less transfer trauma we subject people to, the better. And then there's issues around this access to family and so on. That makes it a difficult situation. Just a little bit about this triage stuff, which I hope that none of us have to deal with. But if we do have a ventilator shortage, I suspect you guys already have some sort of a triage plan in place that takes the individual clinician out of the picture, so that we don't have to decide who gets the scarce resources. Some people, I've seen some of these advanced directives that say, yes, I would be out when I want to be on a ventilator, or there's a middle box that says, well, if there were a ventilator shortage, I would want to let somebody younger and healthier, or with a better prognosis get it. I kind of don't let that. Seems a little coercive to me. I would not volunteer that. If somebody says that to you, like, oh yeah, if somebody else needs it, that's fine. Then that's one thing. But I wouldn't say, like, sort of suggest, hey, maybe somebody else needs it more than you do. And then I think it's really important to make sure that people understand what the comfort interventions are. And in a nursing home, that's mostly going to be, opioids and benzos for air hunger and that sort of thing. But those are readily available, and I think it's important, if we're planning on treating people in place, to make sure that the nursing staff who may have some discomfort with giving high doses of those meds, or giving them on a more frequent basis than they're used to, or even just giving them for dyspnea, that they might need a little help with that and a little reassurance. These are some tools that the coalition has for decision making. I think with respect to COVID disease, the CPR and the ventilator aid and right now they're free. You can download them free and print them up. They're written at a very low health literacy level, and they're very non-value laden. So sometimes I get accused of being oh, you just want to, save money by killing off my mom faster, or that type of thing. No, but anyway, these are just very, very neutral. There's no whiff of, hey, we want you to hurry up and withdraw care or withhold care from your loved one. These documents should be shared with the agent and to the local hospitals and so on. And photocopies and faxes are valid. What if the patient changes his or her mind? It's fine. They can revoke it, and they can also change the person that they want to make decisions on their behalf. And that does happen from time to time. But it's important, if that's going to happen, to do that while the person still has decisional capacity. It's best to just get a new document, void out the old one, and create a new one. So to recap, first thing you do is gather and share information on goals and values, and on the sort of person's medical condition now and what it might be in the future, especially if they were to get COVID disease. Make sure you know who the person is they want to speak for them, person or people. And to the extent possible, make sure that conversation occurs, because probably some of us have had situations where we had a great conversation with a patient, but nobody ever told the family anything about it, and then they feel like they're ambushed when they hear, or they don't believe that the person wanted to be a DNR or whatever. Make sure that the important people get copies of it, periodically review it and make changes, and for people who are appropriate, do a POLST. So last slide, COVID-19 clearly adds another layer of complexity to advanced care planning decisions. And in particular, I think ventilator issues and whether or not to send somebody to the hospital are things that may look a little bit different right now from the way they normally look. Remember that DNR on a POLST form doesn't mean just let me die. And this, I don't really talk about it that much, but dying of dehydration, as probably most of us know, not a particularly bad way to go. And I know you guys have the, I think maybe in Hawaii you call it death with dignity. We call it end of life option act here. Some people don't want to stop eating and drinking and take 2 weeks to die. But for those who do, it's not a bad way to go. It's a lot better than some of the other ways that people die. But I think the public doesn't know that, and to the extent we can help educate them, the better. I think this lack of physical closeness with family is really hard, and certainly iPads and Zoom meetings and whatever, Facebook chats and that, they're a lot better than nothing, right? At least you can see somebody's face, but it doesn't really substitute for a hug, and I think that makes things, it just makes things really hard. And so if you've got people who are dying, try to figure that out early enough that they can, that their family member can come in and have a meaningful goodbye, right? As opposed to waiting until they're already, moribund. And I think for the purposes of advanced care planning, doing remote or virtual visits can be super helpful, and they're fully billable, right? You can use your 99497, 99498 codes. So I encourage you to do that. And in fact, in nursing homes, I think it's a great idea to go around and find people who are full code, this is a good time to revisit that, right? And again, some people don't want to revisit it, but for those who do, I think people really appreciate it. So that's that. And let's see if there's some questions.
Thank you so much for a wonderful presentation, Dr. Steinberg. So for the audience, if you have questions, could you please type them into the chat box and I'll read them out to our speaker. Just to let everyone know, Michaela did put the link for the evaluation into the chat box. You can go in there. And thank you, Jeanette Koijane from Kukuamau, for putting in a website for resources from the California Coalition for Compassionate Care, and also telling everyone we do have virtual notary possible now in Hawaii.
That's great. You guys are ahead of us. I wish we had that.
Okay, great. So if anyone has any questions, could you please type them into your chat box now? Dr. Steinberg, in your experience currently, have you noticed that many patients or their families are changing code status or changing their POLST related to COVID?
I would say a fair number, probably less than half though. I mean, I've tried to go around with all my custodial nursing home residents and had this conversation with them. And I'd say between a third and a half have changed. And a lot of people, there's no reason to change because they still want sort of ordinary treatment. They want selective or what you call limited treatment. They don't want the really aggressive. But I've had a fair number who say, yeah, I do not want to be on a ventilator. And so, you know, we change those orders.
Oh, go ahead.
Well, I'm seeing a question in the box. Do we need to get POLST for every COVID patient of any age? I would say no, because a lot of COVID disease is mild, right? And you know, if somebody's sick enough to be in the hospital, I mean, while you're in the hospital, you don't really need a POLST form because, you know, you're there where all the orders can be done. So I would say the answer to that question is no. For older people or people who have chronic illness, you know, again, a lot of them are asymptomatic. Now that they're doing this point prevalence testing, which I think you'll probably be doing there pretty soon too, you're going to find that there are people who have it that are completely asymptomatic or who have very mild symptoms. So they don't need to get a POLST form, but if they have strong feelings, like I wouldn't ever want to be on a ventilator, then it's a good idea to do that before they're positive, right?
Okay, I'm seeing a couple of questions about the virtual notary, which Jeanette has answered, saying the notary is for the advanced directive. We don't need a notary for the, it's just the signature of the APRN or the patient. Oh, right. It is on. Thank you.
Yeah, so this is Jeanette. This is, it's something that's relatively, it's been a couple of weeks. The notary office came out without us asking. But you can, at the moment, if you have patients that need an advanced directive, it is possible with a notary. You would need then a device, a computer on both sides. The notary would have to see the person and then, you know, show the driver's license that it is the actual person. But that shouldn't be a barrier anymore to getting an advanced directive. But clarifying that a POLST does not need a notary. That's either the physician or the APRN signature, and then the patient or the legally authorized representative.
And one thing that worth mentioning is that you know, a lot of our nursing home residents have dementia and they lack decisional capacity, and so if you have a conversation with a family member who's the surrogate and they want to change the code status, there may be issues with getting it signed, right? I mean, you can always drop it in the mail or something like that, but some, especially in the geriatric population, may not have printers and scanners and fax machines and things like that. So that's one thing that has been considered is, like we used to do in the old days, get like a verbal consent and just have two nurses sign it while you're waiting for the person to send back the original. Have two nurses sign that the person gave a verbal consent to whatever, if it's a DNR order, and that way, you know, you hope the paramedics will follow it.
Okay, any other questions for Dr. Steinberg? Dr. Steinberg?
Can I just clarify, Carl, when you were just talking about that, was that the POLST or the advanced directive in terms of having witnesses? If you could just talk a little bit more about that.
Yeah, that would just be for a POLST form. That would be, for example, if you've got somebody who's been full code, who has dementia, and you know, maybe their daughter lives on a different island, or she lives on the mainland or something like that, and you have a conversation with her and she says, oh, you know, I don't want my mom sent to the hospital, or I don't want, you know, if her heart stops, I don't want CPR. You can fill out a new POLST, you know, the doctor or the nurse practitioner can sign it, and then you just have, if she's in a nursing home, she tells two nurses and they both sign that they, you know, witnessed her consenting to that. And then, you know, because maybe it's going to take a week or 2 weeks to get the actual piece of paper back. At least you've got something written, you know, signed by the doctor and witnessed by the nurses that you hope that they will, you know, push came to shove, that it would be respected.
Yeah, after you talked about it before, I did check in with EMS, and it shouldn't be a problem as long as the signatures are there and we've documented it and all of that. So that shouldn't be any sort of an issue. As always with POLST things, if people hear of issues, especially connected to EMS, you know, please let me at Kakuamau know, because we're the point people for POLST in the state. EMS is very, you know, they feel that they really feel like we've done a good job on POLST, and they want to hear about any issues. So contact us directly with that. Last time it happened, the chief was texting with me within 20 minutes and we got it taken care of. So that shouldn't be an issue. So I see that people are wondering about the virtual notary. So so anyone who is a notary can now act as a virtual notary. So if you find a person who's a notary, they can do this. I will say for Kakuamau members, for organizations and individuals that are members, we are notaries. Hope Young and I became notaries about 1.5 years ago because we noticed so many people wanted to have notarization of their advanced directive, even though it wasn't important or needed. So you can contact us. We please don't publicize it in the paper. And we're only, you know, we're doing this for advanced directives, not for whatever, you know, buying a car kind of a thing. But we would really like to facilitate these advanced directives if that's needed. So feel free to contact us. The easiest probably is if you do info@kakuamau.org, then you get to me and I can get to Hope as well. So again, we need a computer on both sides, and we as a notary have to confirm who that person is, but we can help make that happen.
That's excellent. I just have to say, you guys in Hawaii have done a really great job. And Jeanette, Ida, thanks for inviting me.
I see a lot of people are interested in the notary thing, so please feel free to contact me directly, and we can work on that. And again, this is just because of COVID, but like Carl was saying, you know, if this increase of telehealth, and so maybe some good things can come out of this horrible situation.
Hey, Carl, do you have any concluding remarks?
No, I would just like to thank you for inviting me to come on and share. And I'd like to thank everybody on the call for taking the time to listen and for the work that you're doing out there with this vulnerable population. I think it's scary times for the geriatric population, and this is wiping out a lot of people. And their lives are important, and I think some of the messages that we seem to get suggest that they're kind of expendable. And I know that none of you on this call feel that way. And sometimes you don't know exactly what you can do, but just keep putting one foot in front of the other and doing the best we can to protect them and take good care of them and give them the types of treatment that they want, and always make sure that their comfort and dignity are being looked after, because they are precious.
Thank you so much, Dr. Steinberg. Really appreciate it. You did a wonderful talk. We all enjoyed it very much. Thank you for answering the questions. And Jeanette, thank you for pitching in with some of the questions locally also. So I think that concludes.
So I'm raising my hand because I was trying to find the link. Carl mentioned these really great decision-making guides that the California Coalition has. They cost money, but they're available through the end of the month. So I would really encourage people to go look on the California Coalition's webpage to find those. They're easy to understand and excellent for conversations with the patients. And to clarify too, a couple other people asked me, the California Coalition is like the sister organization to Kukuamal. We're both going on 20 years and we collaborate, and we fortunately get to use materials that they create. And so we really appreciate the collaboration. But I just wanted to send people to go to find those treatment guides. If you can't find the link, again, let me know. And we thank them for letting us there. There you go. Thank you, Carl. You were faster than me.
Yeah, are you guys still using the videos, Angelo Valandez's videos over there?
Only Queens is now partnering with them. We used to have a statewide contract, and now Queens has that. So they've kept up with that. But a lot of we did a few years ago.
Great. Well, thanks again.
Thank you so much.
Thank you, Dr.
Really
Steinberg.
appreciate it.
Okay, bye-bye, everyone. Thank you.
Thank you.